The main new thing in the pathway, in the guidelines, in the very early introduction of the cognitive evaluation with a minicog initially, the previous guidelines said you have to stratify based on G8 score, which is a screening score for in need for a better understanding, a better check for comorbidity. And we strongly suggest that a minicog should be used upfront because patients have to be involved in the decision-making process. And if the cognitive function allow that, it's fine. If it doesn't, it has to be known from the beginning. So the simplest way to do it is to use a minicog. All the other things are almost unchanged with 3 groups of patients that are fit, frail, and too sick. The points I highlighted yesterday are, first of all, that most men with low-risk disease probably don't need to have anything, especially in senior adults. Probably a large proportion of intermediate-risk patients also don't need to be treated at all. This is based on a very large UK randomized controlled trial, the PROTECT trial, with more than 1,600 men randomized between a form of light active surveillance called active monitoring, or radical prostatectomy or radiotherapy. And at 10 years, the specific survival in the 3 groups is almost exactly the same, almost around 99%. So to be better than that is almost impossible in terms of specific survival. So clearly highlighting the fact that low risk and probably most intermediate risk at 10 years, probably just watch them. The aggressive disease, the high-risk patients based on Gleason score above 7 or a PSA above 20 or DRA with a T3 or higher, clearly the lethal disease. It's not a rapid lethal disease, but it is a lethal disease that is served in a form of active treatment. And the second main message was that ADT monotherapy for those kind of patients is probably not the best ways to go. Again, based on a randomized trial that was published by EORTC several years ago, showing that upfront ADT in those men versus symptom-deferred ADT, there is a very minimal OS benefit for those treated immediately, but surprisingly, there was absolutely no specific survival benefit, which is quite surprising. And there was a suggestion that it was less non-prostate-related death with ADT, which is absolutely counterintuitive, so we have to be very careful about that. But probably the most important thing is that a third of the patients non-treated immediately died without never receiving any form of ADT, clearly suggesting that this form of ADT should be reserved for the man with the most advanced disease with a lot of symptoms that require a form of treatment. All the others should be treated in a different way, probably with a local form of treatment. And the third message is, if you consider dealing with local treatment for senior adults, you have to be aware there are at least two validated strategies. The first one is surgery, the second one is external beam. Both are very valid, except the fact that if you're operating on a senior adult man, you must be aware that there's an increased risk of incontinence and an increased risk of impotency compared to younger patients. But it's a valid option, provided the patient is fit enough to have that and in need to receive it. These are the 3 messages from yesterday's talk. Probably the most important thing is to have an in-depth discussion with patients, because every time we say cancer, the patient has a sort of fear, I will have pain and I will die. Clearly, we must reassure that those men with a low Gleason score based on biopsy, clearly they will never die from the prostate cancer, at least up to 10 years. Remember, PROTECT, 99% specific survival. On the other way, clearly advanced disease, locally advanced disease are undertreated. Clearly they are undertreated. If you consider only ADT, it's a problem. And the urologists and the radiotherapists must be aware that it's not because you're old that you must be treated in only palliative care. Provided you're fit enough, you benefit from it, and that's where the geriatric evaluation comes. So it's a matter of education. You have to educate the urologist, the medical oncologist, the radiotherapists, and probably the best people to do that are the nurses, provided they are trained by a geriatrician team. That's the best way to incorporate. So probably the most important limitation is time and learning to work together with geriatricians that have to be incorporated and involved very early in the process.